I want you all to read what are all the labels and what are all the structures here. So let us start with Abhijit. Abhijit, you start doing it with the first one. So you read all the labels and let us see whether you all understand what are the labels. Read, Abhijit.
Yes, sir. Sir, first one, esophagus, sir.
Hmm.
The innermost luminal structure, there is a layer of stratified squamous non-keratinized epithelium,
Super.
which is sitting on a basement membrane. Beneath this, we have the is labeled as the mucosa, and
Okay.
beneath that we have the submucosa,
Okay.
and after that there is the muscularis externa,
Okay.
and finally the outermost layer is adventitia.
Okay. Why it is not called as serosa? Do you have any idea? See,
Sir,
imagine the one in stomach, they are calling it serosa, but here
yes, sir.
they are calling it adventitia in the esophagus. Do you know the difference?
Sir, it doesn't have that mesothelial lining, sir. Like,
Super. So it is only connective tissue here. There is no lining epithelium here in this portion. That's why it is called as adventitia. To call it as serosa, you have to have the mesothelium there. So that's a very important thing. And why it is important? Because if you see the autopsy when you are doing fetal or adult autopsy, the lower portion, lower one third of the esophagus is adherent to adjacent structures and to the diaphragm. Whereas the upper two third, it's like a lumen, nice mucous serosal surface is there. So up to the upper two third, it is lined by mesothelium. Whereas in the lower one third, it directly communicates with the adjacent structures, and there is an applied aspect there. Since there is no mesothelial cells there, whenever cancer comes in the lower portion, they very easily extend into the adjacent area. So for example, we call it T4 when the tumor spreads to the adjacent area. The chances of T4 esophageal tumor is more in the lower portion than in the upper and middle portion. Do you understand, Abhijit? Can
yes,
you
sir.
repeat it?
Yes, sir. Sir, the upper two-thirds of the esophagus is covered by the mesothelial cells, so that protects it from outward spread of the tumor cells, sir. Whereas
Super.
the lower one-third of esophagus not having mesothelial cells is in direct connection with the adjacent organs, and so the spread of tumor cells is it very easily penetrates to the other organs, sir. So the staging, I mean, the prognosis is
Bad. And another point, here they call it as muscularis externa, and muscularis externa and muscularis propria are the same. Like that, they have not shown the muscularis mucosa there, but can you see the blood vessels in submucosa? So at the junction of the mucosa and submucosa, you have the, I will draw it, you have the muscular layer here. So that muscular layer is not drawn there, and that is known as muscularis mucosa or muscularis interna. It is on the, when compared to the inner lumen, it is internal. So that is muscularis interna, and this is muscularis externa, and you can see blood vessels there to call it as submucosa. So when do you call it cancer, Abhijit? We will finish with that esophagus with you. When do you call it cancer?
so once it crosses the muscularis interna, sir.
Yes, super. Then only
Yes.
you will call it as cancer. Hema, சொல்லுமா படிமா ஃபர்ஸ்ட்ல இருந்து
Yes, sir.
trachea. ம்
Yes, sir. Trachea, it's lined by
ம்
ciliated pseudostratified columnar
ம்
epithelium, sir. Then it has the
சூப்பர்.
basement membrane, and then
ம்
mucosa,
ம்
submucosa, then the
ம்
tracheal smooth muscles, tracheal
ம்
cartilage, and
ம்
then the adventitia, which has the endothelium along with the blood vessels, sir.
Again, there they are calling adventitia because there is no
Because it does
mesothelial
not
cell.
have mesothelium.
And see, in trachea, you don't want that much of muscle. That muscle is replaced by tracheal cartilage. That's why you don't see muscularis externa or muscularis propria in trachea. We don't need muscle for the trachea. That's why the muscular layer is replaced by cartilaginous layer. And as you know, the cartilage is there in trachea and bronchi. From bronchioles, cartilage won't be there. We will see it when we see the lung. Kirtana Devi.
Stomach, first layer is the columnar epithelium, and next is the mucosa. Basement, then it's the basement membrane,
Mm.
And submucosa. Next is the submucosa. Then muscular is
Mm.
external. Last layer is serosa, sir. The
Super.
mesothelium, simple squamous epithelium.
It will look like a simple squamous epithelium. One thing wrong there, they called this as basement membrane, and that has to be muscularis mucosa. Basement membrane is the one that is running all along the glands like that. Whereas this layer, this is the muscularis mucosa. Itana Raj,
Yes, sir.
read this one, ma.
Sir, in small intestine, the first layer is the columnar epithelium, sir. And the next layer is mucosa, and then submucosa, then muscularis externa, and then serosa, which is lined by simple squamous epithelium, mesothelium.
And small intestine is thrown into villi. You
Villi.
see the mucosa in the stomach, it is flat, whereas
Flat.
in the small intestine, it is thrown into villi. Why it is thrown into villi, ma?
For
Why?
absorption.
Super. For absorption, we want to increase the
Surface area.
surface. That's why it is. So the minute you see villi, it is small intestine. That you have to understand. Here, what are the portions of mucosa, ma? Remember, I told you the portions of mucosa. What are they?
Sir,
It's not here, but it will be better seen in the GI tree. So, what are the portions of the mucosa? The lining epithelium, the lamina propria, and the muscularis mucosa. So, there are three portions in the mucosa. Meryl, read the bladder, ma.
Yes,
This
sir.
one.
Start with transitional epithelium, sir. Then they've given basement membrane, and then smooth muscle bundles and interstitial connective tissue, sir.
What do you think? Transitional epithelium, can we use that word?
No, sir. We use urothelium, sir.
Super. And the muscle bundle is bigger in bladder because the function of the bladder is to relax and contract. That need more muscle than esophagus or stomach or intestine. We will see them further. The main point you have to remember is there are 4 layers: mucosa, submucosa, muscularis propria, and serosa. In the mucosa, it's a lining epithelium, lamina propria, muscularis mucosa. Subha, Padima.
Yes, sir.
Number
So,
6.
in form, we have stratified squamous keratinized epithelium at the top layer, sir.
Very good.
And then we have a sweat glands papillary layer.
Papillary layer of dermis, basement membrane.
Dermis.
There are no 4 layers in the skin. Skin we will come back because it is not a luminal structure. This is how a squamous epithelium will look when you see from the top. Can you all see this picture? When you see from the top, this will look like this. But when you cut this and when you see from the side, it will look like this. If it is single layer. If it is multiple layer, then it will be stratified. Depends upon how you are looking. And the squamous epithelium and mesothelium will look alike. Veda Padima 2.1.
Simple squamous epithelium, surface view of peritoneal mesothelium, stained silver nitrate with hematoxylin, high magnification.
What do you see there? You read the labels also.
One is cell boundary, sir.
Okay.
2 is nuclei.
Yes.
3 is cytoplasm.
The nucleus is very lightly stained because it's a silver stain. This is the cell border and this is the nucleus and this is the cytoplasm. Remember, I told you when you are describing the individual cell, first cell border, second cytoplasm, third nucleus. You have to remember that. And here, what do you think, Maveda, amount of cytoplasm? What do you think the cell border? Is it distinct or not indistinct?
It is distinct.
Super, ma. And what is the cytoplasm?
It is abundant, sir, quantity.
Abundant.
Simple squamous epithelium, peritoneal mesothelium surrounding small intestine, transverse section.
So this is the transverse section. The mesothelium is supposed to be here like this. And there will be a basement membrane. All the cells sit on a basement membrane. Only exception is synoviocyte. Synoviocyte is the only cell in our body. The cells lining the synovium, they won't be sitting on the basement membrane. That you have to keep it in mind, and we will see it again when we see the synovium. Kidney, we will come back when we see the kidney. Abhijit, read 2.4, figure 2.4.
Yes, sir. Sir, simple columnar epithelium, surface of stomach, stain hematoxylin and eosin, medium magnification. Sir, starting from left, sir, a simple columnar surface epithelium showing apical cytoplasm and basal nuclei. Beneath that, we have the basement membrane, following which we have the connective tissue, which is a lamina propria.
Okay.
Then the connective tissue cells, then the blood vessels which are present in that. They have labeled the apices of the epithelium, that is the cytoplasm in the oblique section, bases of the epithelium, which are the nuclei in an oblique section, temporary folds, basement membrane, and once again they have labeled lamina propria, sir. And lastly, gastric pits, which are under longitudinal transverse section, sir.
Okay, and what they have not shown there, I will write. I am drawing one thing. What is that? What do you think?
Sir, muscularis mucosa, sir.
Super, muscularis mucosa. And what I am drawing now. So this is the submucosa. So you have to remember that. Why they are doing this this portion and this portion? Because usually all the lining epithelium is single layered. Sometimes they may look like multi-layered, but it is the tangential cut. When you cut like this, you will see multiple layers. So whenever it is multi-layered, you have to see whether it is true multi-layering or cut artifact. Do you understand, Abhijit?
Yes, sir.
So that's why you have to see. And as I told you, the gastric pits can look like this when you cut longitudinally, and when you cut like this, they will look round. Okay, this is what you have to imagine. And this is the lamina propria. Lamina propria, I told you these are minor blood vessels, and you see connective tissue cells. We will talk about connective tissue cells in a minute. Fadima, Emma.
Sir. So this figure shows simple columnar epithelium on villi in small intestine, cells with striated borders, microvilli and goblet cells. It contains hematoxylin and eosin, medium magnification, sir. And on top, first we are seeing villi, sir, which is longitudinal and transverse section. Both sections we are seeing. And then inside that we have central lacteal space, sir. And then smooth muscle layer, which is on transverse section. Then oblique sections of epithelium, cell apexes and cell bases are shown. And then striated borders, then goblet cells are visible, sir. Then 7 is striated borders, then 8 is the basement membrane, 9 are the central lacteal, and then blood vessels, then smooth muscle fibers which are on longitudinal section, then the connective tissues, which is the lamina propria, and goblet cells and the capillary cells.
As you know, this is the longitudinal section and this is the tangential section. Now you know how you can see the longitudinal, and when you cut like this and see, you will see the transverse sections. And another thing you have to remember, these empty spaces are the goblet cells. Goblet cells are nothing but mucin secreting cells, and all the other cells are absorptive cells. Remember how the machine will work when there is no oil. Whenever there is absorption has to happen, it has to be more fluid level, liquid level or semi-liquid level. That's why we have the goblet cells. And when you enlarge the goblet cells, they are more flask-shaped cells, okay, with a basally placed nucleus. Can you see them? So that is very, very important. Flask-shaped cells with a basally placed nucleus. These are all the goblet cells. And the number of goblet cells will be increasing from right to left. Okay, small intestine, it will have, for I am telling just for example, 10 goblet cells per centimeter. The cecum will have 20 goblet cells. Transverse colon will have 40 goblet cells, whereas rectum will have 50 goblet cells, because those are all the area where we have to keep our fecal material more watery. Okay, so that's why the goblet cells are increasing. And another important thing, these goblet cells are coming only from the small intestine. If you see it in the stomach, what can we call, ma? The intestinal cells or goblet cells are seen in the stomach. What will you call, Emma?
Metaplasia, sir. Metaplasia.
Super, ma. Intestinal metaplasia. Okay, so how will you define metaplasia, ma? Replacement of one adult type
When
of
one
cells by
epithelium
another
gets
adult type
converted
of
into
cell.
other mature epithelium and adult mature.
Super. Okay, so that is intestinal metaplasia in the stomach. If you see gastric epithelium in the duodenum, what will you tell, ma? That is also metaplasia. That is gastric metaplasia. Okay, so that happens in the peptic ulcer disease. It's very simple. When the bile comes into the stomach will say, okay, I will turn into duodenum. Okay, that's why intestinal metaplasia is happening. When the gastric acid is going into the duodenum, then the duodenum will say, okay, I will transfer myself into stomach. Okay, do you understand, Hema?
Yes. Yes, sir.
Super.
Yes, sir.
And another point you have to remember, you have to go on high power. You see these fuzzy material, and what do you think? You already read. There is a name for them.
So villi,
I am just
villi,
microvilli. Okay, so they are known as,
microvilli.
see where you read striated borders. Striated borders are nothing but microvilli. Okay, so when you draw, when you take only this portion, we will see on the top this portion, it will be like villi, and then it will be single layer of tall columnar cells, and in between you see the goblet cells, tall columnar cells, and so the nucleus will be in the base, and let us fill the goblet cell with the mucin. So these are the secretory, the absorptive cells, small projections. Okay, and that's why these are known as striated border or microvilli. Villi arising from the villi is microvilli. So where is this villi in connection with the top of the cell, border of the cell? Is it outside or inside?
Sir, it's outside, sir.
Yes, there is applied aspect there. I will draw one cell. Oops, it is columnar cell, isn't it? So the width should be more than, so this is the columnar cell. Okay, this is the basement membrane, and this is the nucleus, and let us draw the microvilli as yellow color. Normally this microvilli is in above. What happens in a disease called the inverted microvilli syndrome? So nucleus is here, and as the name indicates, the microvilli are seen inside the top of the cells. So how this patient will present? This is normal. Okay, this is normal. Whereas this one is inverted microvilli disease, inverted microvilli syndrome.
Absorption, sir. Villi is responsible for absorption.
Super. So when there is no absorption, what do you call?
Malabsorption syndrome.
Very good. So the patient will present with malabsorption. And what age this patient will present, ma?
It's pediatric age.
Yeah, pediatrics, because the malabsorption, this is more like congenital abnormality. This won't happen in geriatric. 80 years la இது மாதிரி வராது. Whereas when they present like this, it is usually in infantile or pediatric age group. You remember inverted microvilli syndrome. And the what stain you can do, CD10. CD10 is one of the marker for this microvilli. In normal, in both normal and inverted microvilli syndrome, they will be present. But in normal, it is above the top of the cell, whereas in abnormal, it is below the top of the cell. And one more thing, Hema, I told you the plasma cells will be there in the lamina propria, isn't it? That they have not marked it. Plasma cells will be there in the lamina propria. There is a condition where you don't see the plasma cells. So absence of plasma cells. What will be the clinical presentation, ma? Or what disease will you think?
IgA deficiency.
IgA deficiency. And IgA, it is what type of globulin? It is gamma globulin. It is A gamma globulinemia. Okay. Read, ma. Figure 2.6.
Pseudostratified columnar ciliated epithelium, respiratory passage, trachea, stain, nematoxylin, high magnification. The right side, cilia is first, and then lymphocytes are seen, then goblet cells are seen, then basement membrane, and then the connective tissues with fibrocytes and collagen fibers, and then mucus acinus is seen. Along with that, serous acinus is also seen.
Okay.
Then on number 8 is cilia, and the basal body is 9. 10 is again lymphocytes. 11 is again goblet cells. 12 is the basal cells. 13 is basement membrane. And then blood vessels is 14. 15 is again serous acini.
Here, two terminologies are new: serous acini and mucinous acini. Acini means gland. So there are two glands, isn't it? This gland and this gland, 1 and 2, let us call. And see the difference. See here, the cells are tall columnar cells with a top empty portion, isn't it? So these are mucin secreting. That's why it is known as mucinous acini. I will remove that. Now you can appreciate tall columnar cells with mucin in the apical portion. That's why it is mucinous acini. Whereas in the number 2, you see serous acini, and they are lined by more like a pyramidal cells, and they have the nucleus in the base, and they have a granular eosinophilic cytoplasm. This we will be seeing more in the salivary gland, but you have to remember salivary gland is mainly serous and mucin. The best example for serous is parotid. The best example for mucinous is sublingual gland. So in trachea, you are seeing the salivary gland like structures, and what is the applied aspect? So tumors of salivary gland can happen in the trachea. For example, mucoepidermoid carcinoma, you think it happen only in the salivary gland, but they can happen in the trachea and bronchi where salivary gland analog structures are present. And another one point, most of the time you will be able to see the cilia. You can see the nice cilia here, isn't it? Sometimes you may not see cilia, but the cilia is arising from basement membrane like thick plate, isn't it? So this is known as basal body. Okay, so sometimes the cilia will be detached, but you can see the very prominent surface membrane. It is not basement membrane. Basement membrane should be at the bottom. This is known as basal body. That's one of the indication it is coming from the respiratory type of epithelium. And again here this is pseudo stratified. You can see this cell is connected with the basement membrane, this cell is connected with the basement membrane, these cells are connected, all the cells are connected with the basement membrane. That's why it is called as pseudo stratified.
It's a transitional epithelium, sir, from the bladder, unstretched or relaxed it can be. So number 1 is a transitional epithelium, now we call it urothelial epithelium, and 2 is a basement membrane, 3 is connective tissue, 4 is venein, 5 is smooth muscle, and 6 is binucleate cell, 7 is surface cell, 8 is connective tissue which contains fibroblasts and the collagen fibers, 9 is arterioles, 10 is smooth muscle fibers in longitudinal section, and 11 is venules.
Yeah, I just want to highlight the difference between the venules and the arterioles. The number of the muscle bundles around them. Here there are more number of muscle bundles, more thicker. Whereas venule is having only one layer of the muscle bundle, and that is the main difference, because both can have only the RBCs. If it is lymphatics, it will be serous fluid. So probably these two may be lymphatics, whereas this is a venule. And other thing, this is unstretched. That's why the cells are looking more squamoid. And you look at the cells on the top. See, one cell is covering more than 2 or 3 cells beneath it. So what are they? What can be called as? If a cell is covering more than one cell beneath it, Kitana Raj? What structure will cover more than when people on one person's head when it is raining?
Umbrella cell.
Super. Okay, that's why they are known as umbrella cells, because they cover. For example, I will take this one cell, and this is covering this cell, this cell, this cell. 3 cells it is covering. That's why it is known as umbrella cells. See this fuzzy border on the top. See, it is like a basal body. It is very prominent, isn't it? Why it is very prominent, ma? See, we all talk about the blood-brain barrier. So it is known as blood-urine barrier. Imagine what will happen if the urine mixes with the blood. So this is blood-urine barrier. That's why it is like triple layered, this urothelium. This is the layer that prevents the urine to come into the blood.
Figure 2.8, transitional epithelium, and here the bladder is stretched. So first is
See the
transitional
difference
epithelium.
between stretched and unstretched. I will just go back to the previous. So this is unstretched. Cells are more larger and thrown into folds, whereas this is flat and cells are becoming, especially the umbrella cells are becoming very flat.
So first we have the transitional epithelium. This is now called the urothelium, and
Very good.
the cells are sitting on a basement membrane. And
Very
then
good.
we see the venules, sir.
Very
And
good.
below that we see smooth muscle, which we see it in cross section. And
Very
then
good.
again on the right side we see from the top surface cells. And in number 6 is connective tissue, which has the arterioles. And number 8 is smooth muscles. Here it's shown in longitudinal section.
In any bladder biopsy, whenever you see transitional or urothelial carcinoma, you have to see whether muscle is involved or not. Muscularis propria, okay, not the muscularis mucosa equivalent or the muscles of the blood vessels. Muscularis propria, because there is a treatment difference. If the tumor is not involving the muscularis propria, then it can be treated with intravesicular BCG or intravesicular mitomycin. But once the muscle is involved, they have to do cystectomy. So whether to preserve the bladder or not, pathology is very, very important. And another applied point, there are some smooth muscle from the muscularis mucosa, and there are some muscles in the blood vessels, isn't it? How will you differentiate this muscle from the muscularis propria? There is a IHC for named as smoothlin, SMOOTHLIN. That IHC, when it is positive, that is in the muscularis propria.
Stratified squamous non-keratinized epithelium, esophagus stain is hematoxylin and eosin is medium magnification. The first layer is stratified squamous epithelium, followed by connective tissue, that is lamina propria, and squamous cells, polyhedral, followed by polyhedral cells, and we have basal cells, some mitosis in the basal cell tissue, and basement membrane is present. Below that, we have arterioles, fibrocytes, papilla connecting tissues, some collagen fibers is there, and capillaries also present.
Okay, it's a squamous epithelium. Why can't you call it as skin? Why are they? I know they labeled it as esophagus, but why can't this be skin? To call it as skin, you have to see the adnexal structures. Okay, just seeing the stratified squamous epithelium, it is not skin.